is the whole 2007 guideline, but it looked at 6 specific areas. If you're interested in guideline production, you can read that. It's a very good guideline. I read it, parts of it at least. And let me see here. Okay, so oops. All right, here we go. So I thought I'd start, before we get into the actual 6 points that the guideline deals with, I thought I would talk about just a little bit of a review of what asthma is, because I think when we start to talk about this guideline and some of the recommendations, it's not quite as obvious as you might think. So asthma is a disease that is typical, it has airflow obstruction that is intermittent and variable. And this would serve to distinguish it in some regards from COPD, emphysema, chronic bronchitis, et cetera. So that's one. So there's a physiologic component to the diagnosis, variable airflow obstruction. And because you have variable airflow obstruction, you have variable symptomatology. So your symptoms in asthma vary day to day, often within a day, especially if you have more severe asthma. And that's typical. The lung function testing you do often reflects that. Second component is bronchial hyperreactivity. In other words, everyone has a little bit of bronchospasm when exposed to cold or extreme circumstances like very dry air, but it's not very much. Asthmatics have more than that. And that, again, is actually a physiologic parameter that can be measured in the lab. And the third, and perhaps the most important one, because it underlines the other two, is airway inflammation. So there's inflammation of the airways. In fact, you should think about asthma as an inflammatory disease of the airways. That's a very important component of the disease. And so when we start to think about asthma, we're going to get into a little bit here in a second. When I was in training, which unfortunately was quite a while ago now, we were taught one paradigm of asthma, and that was the allergic asthmatic. They had high IgE levels, high eosinophil counts, and these were, typically people that got the asthma early on in their life. And so that's the paradigm or the model I was taught. But that is not the model that everyone has. And so I'm going to start here with 2 cases that I've seen during my career. Actually, both of these were seen when I was in practice at the University of Kentucky. So I'll read these to you. Case 1 was a 30-year-old woman with lifelong asthma who nearly got intubated every spring due to exacerbation. She was atopic severely, had been tested positive for multiple things that bloomed in the spring. She required daily prednisone, and she actually received parenteral methylprednisolone in spring multiple times to try to keep her from being placed on a ventilator. She was admitted to the hospital during those times. She worked as a hairdresser. She was married, had 2 children, nice family. She was a native to Eastern Kentucky, very strong family ties. We'll get to that in a moment. Her exam was notable for Cushingoid phases. In other words, she had the moon phase from having been on steroids for so long, and she had expiratory wheezing. She had spirometry revealed when you tested her, she always had obstruction, sometimes worse than others. That did get better with albuterol, as would be typical of asthma in general. And her laboratory showed she had blood eosinophilia and a high serum IgE. We'll come back to 2 events in a second. I'm going to introduce the second patient now. Second patient was a 51-year-old woman with asthma for only 3 years by her report. She had frequent work absence due to cough, reported wheezing and dyspnea. She was on inhaled corticosteroid and long-acting beta agonist, a long-acting antimuscarinic agent, montelukast, azithromycin. She required frequent short courses of steroids. She often obtained those short courses of steroids from physicians in the clinic where she worked as a family medicine clinic. She worked at the front desk. She would get those short courses actually without talking to me frequently. Her exam was remarkable for morbid obesity. She had clear lungs. She had normal heart exam. Her spirometry really showed mild restriction and sort of borderline obstruction. There was really, the times I saw her, no response to albuterol inhalation. Her lab showed a borderline elevated IgE, was not super high. It was kind of in the gray zone, and she had no eosinophilia. Now I have to point out that during these testings, both blood and PFTs, she was on these medications, the inhaled corticosteroids. She had had extensive workup, including bronchoscopy, airway biopsies, and assessment of her upper airway. And it didn't really show any other diagnosis that I could tease out with those testings. So we'll go to what happened. So the two events. Case one, the 30-year-old woman with classic allergic asthma. She had a hip replacement due to avascular necrosis. She had been on so many steroids at her young age of 30 that she required a hip replacement from that. And so that sort of was a sentinel event that beyond the usual caught my attention. The young woman had to have a hip replacement due to her steroid use. Second thing was she came back to visit me one time. I remember distinctly after going on a vacation to Florida. I think she went to the Tampa area. And she came back to me and she said, you know, while I was down in Tampa, my asthma was a lot better. Okay. And so these two things together launched us on a path where ultimately I told her, what I want you to do is I want you to go down to that area of Florida again, where she had some friends, and I want you to spend 2 or 3 weeks there. And then when you come back to Kentucky, I want you to drive straight here, basically. I'm going to check your lung function tests. And they were a lot better because it's a very different set of allergens down there in Florida. And after we had to, there were several clinic visits I remember with the extended family saying, are you sure you want my patient, you sure you want my daughter-in-law, et cetera, to move to Florida? And I said, well, I'm not telling you to move anywhere. I'm telling you that this woman has a significant problem. She's had a hip replacement and she almost gets intubated every spring. I think she probably should strongly consider doing so. Ultimately, the family decided to move there. And she came back one time after that to visit family. And she said, since moving there, the only medicine I require is PRN albuterol. So that's classic allergic asthma. You take the allergen away, the disease gets much, much better. Second case is not that. I kept trying to start her on some immune suppressions and biologics, and we were always having difficulty. She would have some symptom that was somewhat vague to me, and she would stop the medications after just a week. So we never got anywhere there. I was talking about multiple things to make her better. And I mentioned that the last clinic visit I had, one of the things she might consider is weight loss, because, you know, even if the asthma she has, we're treating it as best we can. If we could lose some weight, she'd feel better, she'd have less dyspnea. And at that point, she got very offended and fired me. And so those are the two cases, very different. So think about those as we go through the following slides. So one of the things I want to point out, and I hope I've alluded to it already, is that asthma is not all just one thing. There are different phenotypic features. And so here are a list of some of those features. So the first case is a classic atopic or allergic asthma. But there is occupational asthma. They're very well-defined, thankfully not that common, but well-defined occupations that lead to asthma that if identified, you can ameliorate them by getting them out of the occupation or the particular job they do. There's adult onset asthma, which is different from the asthma that occurs in childhood and persists. There's post-infectious asthma, classically influenza, but chlamydophilia can do it as well. There's allergic bronchopulmonary mycosis, its own diagnosis. But if you miss that diagnosis because it presents like asthma, exactly like asthma, you have to have a keen eye there. And then there's exercise-induced asthma, which is just exercise-induced. They don't have symptoms at other times. So without going too much into it, people have been looking into this for quite a while now. This is a paper from 2010 where these researchers looked at a large group of asthmatics and tried to cluster them into their phenotypic features. So they came up with 5 clusters. 1 and 2 are just allergic asthma. One is milder allergic asthma. 2 is more severe allergic asthma, not terrible. Cluster 4 and 5 is severe asthma, could be allergic or not. And I think my first case would fall into this category because she was so severe. But I'm pointing out, or I've outlined cluster 3. Cluster 3 is the second case I presented, the 51-year-old woman. There is this cluster of older, typically obese women who have late onset asthma. They have moderate reductions in FEV1, use oral corticosteroids due to exacerbations. And when we get into it, they respond fairly poorly to inhaled corticosteroids. So just remember this, not every asthmatic is the same, and that is a theme here. So let's talk a little bit about difficult to control asthma, because if asthma was easy to control, we probably wouldn't be having this echo session right now. So here are some things to think about with difficult to control asthma. If you see asthma in your practice and the patients aren't doing well. So the first thing to think about is adherence to treatment. So adherence to treatment can be really difficult in asthma, especially if you deal with children. Now, I'm not a pediatrician, so I don't deal with children. So that's a limitation for me in this talk. But there's this really good study from the Netherlands of difficult to control asthma. They did a very good research assessment, and they found in this large group of patients, I mean, thousands and thousands of patients from a registry, that they had difficult to control asthma in about 17% of these patients. When they looked closely using tools to assess medication use and inhaler technique, when they excluded those two things, people that are actually using the medicines and using them correctly, only 3.6% had actually severe refractory asthma. What does that say? It says one is patients don't always get all the medicines and use them correctly. And two is, and this is a key point when you're dealing with these patients, you need to assess their inhaler technique. It's not enough just to tell them how to use it. You have to actually show them and get them to show you, to teach back to you how they use their inhalers. That is a key thing, especially in the patients having problems, because until you do that, you really don't know. I've seen people do this with their inhaler, and that's their inhaler technique. And that medication does not get to the business end of the lung. You have to use very specific technique to do that. And even if you use best technique, you only deposit a minority of the drug in the lung. So if you use poor technique, you might get zero. Now, there is relative resistance to corticosteroids, and some of these subtypes of asthma fall into this category. And it persists despite high dose inhaled corticosteroids and good adherence. And then we'll talk about this in the next slide or so. The inflammation is related to non-T2 mechanisms. So T2, that mechanism refers to the T cell lymphocyte. Basically, T2 mechanisms are your allergic asthma. T2 mechanisms cause allergic asthma. But here's the thing. About 50% of asthma patients do not have eosinophilia or a high IgE or high exhaled nitric oxide. And those non-T2 mechanisms are important in those patients. So when we talk about that, we're going to talk about asthma phenotyping. I think this is a key point to take home. I don't want to get too basic in science for everyone, but this is key because we just said that about 50% of asthmatics are not allergic or have T2 mechanisms. So I'm going to just divide them. Again, this is a bit of a hyperbole because not everyone is either eosinophilic or non-eosinophilic. Some people are mixed, but let's just look at these two paradigms for. So eosinophilic asthma is your allergic asthma. These patients have high Th2, again, that's T helper cell 2 cytokines. Those cytokines recruit B lymphocytes that produce IgE into the airway. They recruit eosinophils, and they recruit mast cells, which cause immediate reactions to inhaled allergens. These patients will have high blood and sputum eosinophils. They'll have high serum IgE levels. They'll have high exhaled nitric oxide, which basically is a function of the Th2 inflammation. They are atopic or allergic. And these patients have good response to inhaled corticosteroids. And I will say this, these patients are the ones that have more frequent exacerbations. The eosinophilic allergic asthma have more frequent exacerbations, but it's only about 50% of the group of asthma patients. Then you have the non-eosinophilic asthma. These have decreased Th2 cytokines. Some of them have Th1 cytokines, and instead of eosinophils, they have neutrophils in their airways. These are more likely to be cigarette smokers. They're more likely to have bacterial infections and an altered microbiome of their lung. They're more typically obese. They'll have decreased vitamin D level, and these importantly respond poorly to inhaled corticosteroids. They do have less exacerbations than the eosinophilic version, but this is very important to recognize this phenotype. And again, this is the second case I presented to you. So to work up a patient with asthma, you need to do a thorough history. So really what you need to look at is the attention to the date of the onset. Do they have allergic features? In other words, does it occur in certain times of the year? Do they have sneezing, watery eyes, runny nose, these sorts of things that go along with allergies? What do they do for work, and what other things they do? You might uncover occupational asthma. For instance, if the patient's someone who works baking, that is a well-established risk factor for occupational asthma. Prior respiratory infections, especially if their asthma onset came after a respiratory infection like influenza. That's a big clue to the etiology of their disease. And then environmental exposures, especially pets, the cat, dust mites. What triggers them? Do they smoke? There are others, but these are some classic ones you need to look at. I would strongly suggest if you're managing asthma patients, anything more than just mild disease, you should check their blood eosinophil count, and you should check their serum IgE level. Those are two things that will help you sort of phenotype your patient a little bit, and it might actually direct you toward biologics if they're that severe. You should get a chest image at some point in their workup. It should be normal. I think that's reasonable, again, in any person that's more than just a mild asthmatic, because there are diseases you might be missing that can manifest similarly to asthma. And everyone with any amount of asthma that's significant should have a lung function test, particularly what I'm talking about here is a spirogram and assessment of reversibility. And for asthma patients, and I show you a figure down here, asthma patients, they should have FEV1 should improve by 12% and 200 cc's after inhaled albuterol. They can do this in the lab for you. And if you look at any study of asthma treatment, they're going to have this criterion that they have airflow obstruction of even a mild degree, but it has to have some improvement. And that's what you're demonstrating there, is that bronchial hyperreactivity and reversibility, which is the hallmark of asthma. So when you assess an asthmatic in the clinic, if you only had a very brief visit, you have 2 questions to ask. These are your 2 questions. Again, this table is taken from the 2007 guideline. This has not changed in the 2020 guideline. This is still up to date. And so the 2 questions are, do you wake up at night for respiratory symptoms? Here we see night outlined in red, nighttime awakenings. Here's the age in years. So I just direct your attention to, greater than 5 years of age here. And how often do you use your rescue inhaler? We use short-acting beta agonists, or SABA. How often do you use that rescue inhaler? And so for mild intermittent asthma, step 1, everything's intermittent. You can't wake up more than 2 times per month. And if you use your inhaler more than 2 times per week, you're not intermittent. You're over here now. And that's the key point. And then you can grade throughout these 2 symptoms, very quick to ask these 2 questions. You can find out where your patient lies. So now, with that behind us, that little intro, we can talk about the 2020 recommendations. So if you look at the guideline, these are listed in order. These are the 6 key questions that the working group came up with that they wanted to address for 2020. And so they are.
I'm on a call right now. Oh, okay. Go in, talk to Kelly.
Exhaled nitric oxide, indoor allergen mitigation, intermittent inhaled corticosteroid use, long-acting antimuscarinic inhalers, immunotherapy, and bronchial thermoplasty. So I will go through these in order. Try not to spend over much time on them, but if you have questions after I'm done, we can certainly get into that. So from what I just said about Th2 inflammation and how it's important to phenotype your patient to some extent, exhaled nitric oxide is produced by eosinophilic airway inflammation. So high levels of exhaled nitric oxide are typical of this disease. That would be allergic asthma. Remember, that's about 50% of the group total. And so if you measure this, if you have the ability to measure this, and a lot of offices do this who deal with asthma a lot, if it's elevated, it correlates with that Th2 inflammation, the eosinophilic, the allergic asthma. If you have low exhaled nitric oxide, it suggests an alternative diagnosis, in other words, not allergic asthma, and or recent or current corticosteroid use. So if you treat someone and you test them while on treatment, their exhaled nitric oxide should drop, and actually you can use that perhaps to even monitor the utility of therapy. So who should you use that in? Well, children, you can use that if they have allergy, uncontrolled asthma. And if you're considering an add-on therapy, you want to see if this is working or not. It's basically something that could be used to monitor their response to treatment and actually to see what kind of diagnosis they have. Are they allergic, eosinophilic asthma? Do they have asthma at all? Or something else? So here are the two recommendations that the guideline came up with. So in patients 5 years of age and older, who the diagnosis is uncertain, so that's key. After you've done your complete evaluation, if the diagnosis of asthma is uncertain, especially if it's allergic asthma, the expert panel conditionally recommends using an exhaled nitric oxide measurement as an adjunct to the evaluation process. Their evidence summary was moderate certainty, quite a few studies out there. So the point here is if you have access to this, this can be helpful in the patient who's the diagnosis is uncertain. If it's a slam dunk, you don't really need it. But it does add something to the diagnosis of asthma when things are not clear. Recommendation 2 has to do with ongoing management. So these are, again, this recommendation for both of these were patients 5 years of age and older. So if they have persistent allergic asthma, so these would be patients with Th2 inflammation who should have a high baseline exhaled nitric oxide level. But if you're not sure, if there's uncertainty in choosing, monitoring, and adjusting therapies, they conditionally recommend you can add an exhaled nitric oxide measurement as part of an ongoing asthma monitoring and management strategy, but you have to do it frequently. So just doing it once a year is not really doing much. We're talking about a patient that you're committing to seeing regularly, who is having problems. You may be adding or considering adding new therapies. Now, the evidence summary was lower certainty. There were 6 randomized controlled trials of a number of patients. And what they found, if they added this strategy, they had 67 fewer exacerbations per 1,000 adults. And they defined that exacerbation as an exacerbation that required oral corticosteroids. So this is not as strong a recommendation, but certainly something to consider. I would just point out again, if you're going to do this serially to measure the response, you have to do it frequently. You're committing to not just once yearly or twice yearly visits. You're talking about something more frequent than that. And I think that's basically exhaled nitric oxide. So we'll talk about indoor mitogen mitigation. That thing in the corner there, that scary looking thing that might give you nightmares, is a dust mite. It's pretty scary. I'm glad I can't see them all the time. So there was recommendation 5, 6, 7, 8 regarding indoor mitogen mitigation. So indoor mitogen mitigation, it's things that you're allergic to, they're triggering your asthma indoors. We're not talking about flowers and trees and grasses now. Things that happen inside your home or the place you live. And so, a lot has been put forward on this. There's a lot of recommendations that are, no one really knows. I really didn't know. I was told things in my training about indoor mitigation, dust mites especially, and cats. But, there was not a whole lot of information. And truly speaking, again, that's a long time ago that I went through training. There's not a whole lot more information now than there was then. Good solid evidence. So here's recommendation number 5. If patients who do not, if you test them for sensitization to dust mites, which I would recommend if you have a patient with true allergic asthma, they probably do need allergy testing if they have significant disease requiring significant medications. If they don't have sensitization to indoor allergens, there's no evidence at all that doing anything against allergens inside the home is helpful, and that makes sense. So you don't. So a patient who doesn't have it to indoor allergens, you don't have to recommend anything for it. On the next slide, I'll show you what some of the things have been recommended. Recommendation 6, patients who do have exposure to indoor allergens, and this has to be confirmed by history taking, but specifically almost, I would suggest, true allergy testing, proving that they have this allergen and it's significant. They have significant asthma and they have the allergen. They recommend, and here's the key word, a multi-component allergen-specific mitigation intervention. Multi-component. Just remember that word, multi-component. That's recommendation 6. So these are patients that have allergic asthma. They have allergy testing. It's positive. They say maybe conditionally recommends a multi-component. Recommendation 7, who have sensitization to, again, more on the same theme, sensitization or symptoms related to exposure to pests, cockroaches, and rodents, which can, they have allergens clearly associated with some patients. This is important. They conditionally recommend integrated pest management as a part of a, here we go, multi-component allergen-specific mitigation intervention. And recommendation 8, patients who have asthma and sensitization related to dust mites. So they've been tested, allergy tested, they have sensitization to dust mites, which lives in the dust. It's crazy things up in the picture. They recommend these pillow and mattress covers only as a part of a multi-component mitigation intervention, not as a single component intervention. So I'm guilty here. I've recommended this to patients a lot in my time. I don't think it really ever worked. And again, this would be the evidence. It's not shocking, but the evidence summary for all of these recommendations are only low to moderate certainty. There's not a lot of great evidence. And let me show you what some of those interventions are. So all these below are listed in the guideline. So impermeable pillow mattress covers, I've done that, recommended that. Air filtration and purifiers, integrated pest management for cockroaches, rats, mice, acaricides, they kill dust mites, HEPA vacuum cleaners, carpet removal, I've recommended that. Certain specific cleaning products that tout themselves as getting rid of dust mites, etc. Mold mitigation strategies. Pet removal, there's Hello Kitty saying goodbye. All of those things. So the evidence out there is not good. It's either heterogeneous, insufficient, or mixed results for all these things. And the point, again, going back to that key word, multi-component. If you're going to go this route, first you should test the patient to see that they're truly allergic and they have asthma, that's a problem. And then if you're going to go that route, you know there's some indoor allergens that are relevant. You need to go with multiple things, not just one component. If you're going to commit to this, you need to go all the way and do multiple things, not just one thing. And that's just these recommendations in a nutshell. Okay, so that's indoor mitogen mitigation. So here's the recommendation that I found most interesting, I think, and I think this is the most important one, actually, but it's listed 3 in the guidelines, so I dealt with it 3, but I think this is number 1 in importance, is the intermittent inhaled corticosteroid use. So I copied the table again over here and outlined it slightly different to look at mild and moderate asthma, persistent asthma. And I outlined, nighttime awakenings. Again, this is for greater than 5 years of age, nighttime awakenings and rescue inhaler use there in the second box. So remember, for asthma is an inflammatory disease of the airways, and the anti-inflammatory inhaled corticosteroids are the mainstay treatment for asthma above step 1, which is the very mild intermittent asthma. Everybody else above that, you need inhaled corticosteroids as the mainstay of treatment. And so these 3 recommendations here, recommendation 9, 10, and 11, these are on patients with well, we'll start with 9 because that really deals with patients age 0 to 4 years. So these are young patients who have, mild asthma but have recurrent wheezing and triggers. And so they recommended, usually those patients just get inhaled rescue inhaler or SABA for quick relief. But the guideline recommended starting a short course of daily inhaled corticosteroids for patients 0 to 4 years of age who have recurrent wheezing that is triggered by respiratory tract infections. So that's a new recommendation in the pediatric age population. As needed, a short course of inhaled corticosteroids triggered by recurrent wheezing from respiratory tract infections, other than just giving them a rescue inhaler alone. It's a high certainty of evidence, a conditional recommendation. Recommendation 10 and 11 are for patients above 4 years of age. So 10 is for 12 years of age and older, and 11 is for 4 years of age and older. So these are both in patients who have mild persistent asthma or mild to moderate persistent asthma. So 10 is saying if you have mild persistent asthma, that would be up here. I don't know if you can see my cursor pointer, mild persistent asthma here. They recommend either daily low dose inhaled corticosteroid and as needed rescue inhaler or quick relief therapy, or they say you can use as needed inhaled corticosteroid and SABA used concomitantly. This is different. When I was in training, we didn't talk about as needed inhaled corticosteroids. You had to use them daily like antihypertensives. So that's been a change here, using them as needed, because again, it's getting at the idea that the inflammation of the airway is so important. They wanted these patients to use them more frequently than they were. So that's for those patients. Now, for patients with mild to moderate persistent asthma, again, the groups boxed above who are adherent, they recommend against just upping the short-term increase in inhaled corticosteroids for those patients, probably adding something else. And so going from a moderate dose of inhaled corticosteroid to a high dose of inhaled corticosteroid on short term probably doesn't do that much in those patients if they were fairly well controlled before, because inhaled corticosteroids tend to have a flat dose response curve. But think about that for a second. We're going to go to the next slide, which is also inhaled corticosteroid. Recommendation 12 and 13, again, these are for patients 4 years of age or older. And this is really, I think, the biggest one of all the recommendations. The expert panel recommends a specific drug, inhaled corticosteroids with formoterol as the long-acting beta agonist, and a single inhaler, both as a daily controller and a reliever. That's a big change. Usually it was you used the combined inhaled corticosteroid, long-acting beta agonists, use that drug as your controller and a rescue inhaler as your reliever. They've gone away from that now. They say use the ICS formoterol and a specific drug, formoterol. And the reason why formoterol is it's a long-acting beta agonist that has a quicker onset of action than the other drug, salmeterol. So formoterol acts quicker. So they recommend that as both a controller and a reliever in patients with moderate to severe persistent asthma. That's a big deal. And so they recommended that. Now they did say if the patient's already well maintained on the old regimen of the ICS LABA, which is not that, and with a rescue inhaler, they're doing well, you can keep them on that. You don't have to change these patients. But for the new patient or the patient who's not doing as well, they recommend this change. This is a strong recommendation with a high certainty of evidence for ages 12 years and older, and moderate certainty for 4 to 11. That's a big change in this guideline. They recommended that the daily dose of formoterol should not exceed 12 puffs for ages 12 and older. So here's the thing, and this is why up in the corner I have these two drugs. This one, which I will not say its name, is the one you can get in America, and this is the one you can get outside of America. But that's the drug you get. That's really limitations. But this is the guideline, and the ICS formoterol is preferred over other ICS LABAs for moderate to severe asthma that conform to this. That's a big change. So to me, that's the most important thing in this guideline. These two slides I've showed you about intermittent inhaled corticosteroid use. And I know I read it to you, but I think going over it would probably be useful if you're seeing these kind of patients in the clinics. So let's talk about long-acting antimuscarinic inhaler. And these are the two ones that you can get individually. Now, they're combined drugs that put all these together. Again, I'm not going to say the names, but these are the ones that are available here, I think, in West Virginia. So these are 3 recommendations here. So at recommendation 1, they recommended for adult patients 12 and older against adding these drugs to inhaled corticosteroid as opposed to long-acting beta agonists. So the long-acting beta agonist is better than the LAMA in asthma. Now, if you can't get, for whatever reason, you can't get the LABA, the long-acting beta agonist, like formoterol, for instance, you can't get that for whatever reason, whether they have a reaction to it or whatever, you can add this drug to inhaled corticosteroid. Remember, the inhaled corticosteroid is the key drug in this disease. It's a conditional recommendation, moderate certainty. And if the patients are so severe that they are not controlled on high dose inhaled corticosteroids and the LABA, what we talked about, you can add the long-acting antimuscarinic inhaler to that. But the bottom line is this, and here's those 3 recommendations are this. If you have a patient with poorly controlled asthma, the LAMA, these drugs are inferior to the LABA. Okay, those drugs do not work as well as formoterol or salmeterol, but they're better than nothing. So again, the strong recommendation, if you have a patient with poorly controlled asthma, or it's inhaled corticosteroids, and I guess formoterol, you don't just go inhaled corticosteroids to the antimuscarinic unless there's some outstanding reason for that. Patients aren't doing well in the ICS LABA, you can add the LAMA. There was no inadequate evidence to talk about montelukast, and in fact, montelukast now has a black box warning, so you need to think about that. So that's key, because I think the problem, and again, this gets to the idea of accurate diagnosis. If you're dealing with patients with COPD, you might start with the long-acting antimuscarinic inhaler, but that's not the case for asthma. So diagnostic accuracy is also, again, important here. Okay, I'll move on. Immunotherapy. So immunotherapy basically means that they give you an aeroallergen, something that you are proven to be allergic to already. They give it to you. Typically, it was subcutaneous injections over time. That you developed IgE antibodies, and when you were exposed to that, inhaled that allergen, you reacted with the IgE, it cross-linked the mast cells receptor, and mediators of asthma released. That's the classic sort of atopic asthma model. But when immunotherapy administers smaller doses of this allergen, usually subcutaneous, and it attenuates the response to when you get exposed to this, probably through the production of blocking antibodies, which blocks those receptors on the mast cell. That's the idea. Now, remember, when we say immunotherapy, I want to say clearly, you want to test to prove that they have this. You're not just, history alone is inadequate to recommend immunotherapy. So, recommendation 17 and 18 have to do with immunotherapy. And so in patients that are 5 years of age and older, they maintain that subcutaneous immunotherapy, getting injections, as you classically would at the allergist office, is an approved of adjunct to standard pharmacotherapy. So standard pharmacotherapy, it's the thing you do after everything else has been inadequate, or you still have, say, rhinitis symptoms. I was always taught during fellowship that immunotherapy is really good for upper airway symptomatology. It's less good for lower respiratory, the wheezing, the shortness of breath that you get with asthma. And I think that's, in so many words, where they come down on it. It's helpful with asthma, but it's not the primary therapy. The primary therapy of asthma that is symptomatic, especially anything other than mild intermittent, is inhaled corticosteroids, and then you can go from there on the step chart. Okay. Recommendation 18 is they recommended against the use of sublingual immunotherapy. Not enough data, they said. So it's still shots. And so the key language for both these recommendations is this: asthma should be controlled initially. In those individuals, asthma is controlled initiation, buildup, and maintenance phases. You control the asthma first, then you can add this on to help as an adjunct. It's an adjunct to standard pharmacotherapy. And that's the key points on this. And this is the last one, bronchial thermoplasty. So bronchial thermoplasty is a modality. Here I show you a cartoon diagram of a bronchoscope wherein they've put forward this probe. It looks like a basket retrieval device we used to use, but this particular thing has heat energy delivered through it. So the bronchial thermoplasty is a modality that does a thermal injury to the large airways. The idea here is reduce your asthma symptoms by basically killing off some of this extra smooth muscle that is bronchoconstrictive, causing the symptomatology. And so that's what bronchial thermoplasty is done in a number of specialized centers. It was done at the University of Kentucky when I was there. So here's recommendation number 19. In adults, so 18 and older, the expert panel conditionally recommends against bronchial thermoplasty. It's a conditional recommendation. There's low certainty of evidence. So what are they saying here? Never do bronchial thermoplasty. I don't think that's what they're saying. What they're saying is this is a niche or add-on procedure in very selected patients. You don't get asthma and send the patient to get this procedure. So are there indications? Sure. I would say these patients have to be carefully evaluated after everything else reasonable has been tried. So patients with poorly controlled symptoms, despite appropriate pharmacotherapy, including an assessment of adherence and inhaler technique. So you need to make sure, one, that you're giving them the best therapy that you can get them. They have to be adherent and they have to have proper technique. Now, if you look through all of that, the patient's still very limited, having problems, sure, you could consider it. But remember, this is the point. It's a niche procedure that should be considered only after failure of the standard treatment over some other individualized situation. So that's the point here. You're not just referring people for bronchial thermoplasty because they have asthma and take an inhaler twice a day. That's not what they're saying. And so I hope that's clear. So I'll come to my summary slide. So summary is asthma is a clinical syndrome with several different underlying pathological processes. So remember, this is intermittent airflow obstruction. You can show it on a pulmonary function test. They have bronchial hyperreactivity, and this is all related to airway inflammation. So the key point is diagnostic accuracy. This is not congestive heart failure with wheezing. A lot of patients who go into pulmonary edema do wheeze. That's not necessarily that. This is not COPD. So you need to do a careful diagnosis of these patients. And so once you diagnose it is asthma, they have these features of variable or intermittent airflow obstruction inflammation. I would say strongly suggest you do a little bit of phenotyping that begins with a solid history, going over the points I outlined for you. And then I would strongly recommend doing some sort of phenotyping with a serum IgE level and an eosinophil count. If you have access to exhaled nitric oxide in patients who do not have a clear diagnosis, I think that's a useful adjunct because it correlates with those two parameters, the eosinophilic inflammation. So the recommendations in order of, now I've reorganized these recommendations in order of importance to my particular practice. I'm a general pulmonary critical care physician. I don't have an asthma per se practice, but I do see asthmatics in clinic. So my number one recommendation was ICS formoterol as both a controller and a rescuer for moderate to severe persistent asthma. And those are the patients I tend to see. They don't send mild patients to the university, at least in my general practice, especially at the University of Kentucky. So I see people that are at least moderate. So that's a big change. Short course and PRN inhaled corticosteroids for exacerbation of mild or persistent asthma. That's another one. So, short course inhaled corticosteroids, I never really done that or heard about that, but now it's a thing, especially in young kids. Number 3, LABA, long-acting beta agonist, is superior to long-acting antimuscarinic inhalers in asthma, where it's different from COPD. Again, another reason for diagnostic accuracy. You might start a LAMA in patients with emphysema. You wouldn't do that in asthma. Exhaled nitric oxide can be helpful in the diagnosis and management of asthma. If you have access to this, remember, if you're going to use it in a management strategy, you have to see the patient frequently. Sub-Q immunotherapy is a useful adjunct for atopic asthma, not sublingual. And again, you want to control the asthma with the standard pharmacotherapy before you embark on that as a treatment for asthma per se. Now, if you're treating upper airway symptoms, that's somewhat different. Bronchial thermoplasty should only be considered after failure of usual pharmacotherapy. We just talked about that. And then indoor allergen mitigation should only follow documented allergy and be multi-component, not just one thing that you see on advertisement. You're committing to multiple things to try to deal with that. Again, after you've proven it with testing. And that's my slides. I have a few minutes before I have to round in the ICU at 9 o'clock, so I'll be happy to answer a couple of questions.
Thank you so much, Dr. Moorhead. That was awesome. And we really appreciate your time. And even those 2 cases you inserted in there was super helpful. We did get a couple questions in the chat, but before we get to those, did anyone have any questions for Dr. Moorhead or comments that they wanted to unmute and ask?
Sure, I have a quick question. You talked about using inhaled nitric or exhaled nitric oxide as diagnostic for people with eosinophilic asthma only, specifically. And my question is it sufficient to call them eosinophilic asthma based on elevated serum or blood eosinophils, or does it have to be BAL eosinophils to call it eosinophilic asthma?
No, I would say if you have a blood eosinophil count, and I think there in the literature, there's a different cut points, but usually I'd say at least 220 eosinophils or perhaps even 300 eosinophils per cubic millimeter. If you look at the absolute count on your CBC with differential, that's probably enough. Now, serum IgE levels, similarly. I guess the thing is, if you have access to exhaled nitric oxide, you can do it real time in your clinic, and you don't have to wait to send a blood test. So I think, again, the exhaled nitric oxide is a proxy for eosinophilic inflammation, but if you have the other, but we don't do a BAL, I don't think that's necessary.
Okay. So, but you're saying this is, I guess what I'm trying to get at is, so the second part of the question was, you can't use that in place of spirometry. This would just be for somebody with equivocal spirometry, maybe you could use that to kind of, or symptomatically, clinically, you think they have it, but their spirometry, or they can't do spirometry well, or for whatever reason, it's just kind of an adjunct, or can it be used in place of spirometry to make that the asthma diagnosis?
Oh, I see what you're saying. No, I think you have two separate things there. One of them is when you're looking at exhaled nitric oxide, what you're looking at, in my view, again, the clinics I've worked at don't have the access to that. But what you're looking at is a phenotyping of the kind of asthma you have, an eosinophilic versus a non-eosinophilic. Remember, about 50% in each camp. That's a proxy for that. The exhaled nitric oxide is a proxy for Th2 inflammation, which leads to eosinophilia and high IgE allergic asthma. The spirometry is you're grading the severity and control of their disease, irrespective whether it's eosinophilic or non-eosinophilic. Does that make sense? Okay.
Awesome. Thank you so much for the question, Dr. Werntz. We do have one more question in the chat. If you have some time, Dr. Moorhead, I know you have to go to the rounds soon, but the one question we did get was asking the definition of the word mitogen. Does that refer to mites?
No, it doesn't. What is the definition? Good question. Myogen is an allergen in the environment that I think you inhale. I think that's what it means, but I'd have to look that up. But it doesn't refer just to mites, I don't think. That's a great question. That's the language they use in the guidelines. I'm looking it up right now. Let's see if Merriam-Webster has I don't think so. I don't think it's just mite, because I think it refers to cats as well, and fungus, and et cetera.
Awesome. Thank
Anyway, but I don't think it's just might.
That's great. Thank you so much for clarifying. And then the last question was sort of just referring to the cost of FENO instruments. If you knew.
I don't know. Actually, I've never had the opportunity to have it. The allergists typically are where those are, asthma specialists have it. I don't know how much it costs.
Awesome.
One other question, Mitra, and that was, Dr. Moorhead, that was great. Thank you. And this kind of relates to what Dr. Lawrence was asking about blood EOs. Can we use CBC with diff for the blood EO determination, or do we have to do an absolute EO count?
Well, that's an interesting question. So when we order a CBC with diff, if you look at the, it'll give you the percentages, and then it should give you the absolute numbers below that. At least in the labs I've worked with, both here and back in Kentucky, they did that for you. So that would give you both a percentage and an absolute number. So I don't think you have to, I shouldn't, at least I don't, your lab is, you might want to take a look at your lab results, but in our lab, we get that when we just order a CBC with diff.
I don't think that's universal. We don't.
Okay, well then I guess you do need to then.
Or we can just use the percentage of EOs times the total white count. Carl's got a thumbs up on that.
Absolutely, yep, you can do that. That's
Okay.
multiplication though, and we're just doctors.
But the number will be much likely to be used if we can. I mean, I think we should routinely look at our CBC and diff, at least do that.
Yeah, absolutely. Yeah,
Because usually that's available.
the reason why that make a big deal of that is occasionally you have patients with very low white counts, and it looks like they have impressive eosinophil counts because of the percentage, but you have to actually look at the numbers. But again, 300 eosinophils is not a really high number when you have someone with a normal white count.
Right. Thank you.
You're welcome.
Alrighty, we'll give you a few minutes to get to clinic and everything and rounding Dr. Moorhead. But before we get into announcements, I just wanted to thank you so much for doing the guest presentation today. It was super helpful and such great information. We were getting chats in too, thanking you very much for that. So we truly appreciate your time.
Oh, no problem. I enjoyed it.
Thank you. And we'll definitely have you come back and give another presentation sometime in the future.
Okay. Well, thanks so much. Take care.
Thank you.
The only announcement I do have is that our next session will be on June 21st, and Dr. Sangani will be presenting on idiopathic pulmonary fibrosis. So keep an eye out for that reminder, and we'll see you all next time. Thank you.
Bye.
We have a question